Cardiac tamponade is the high-pressure emergency, the point where the physical restriction of the sac immediately threatens the heart's ability to function.
If the acute inflammation is the fire, tamponade is the suffocating pressure cooker. It's defined as the accumulation of fluid in the pericardial space that is sufficient to obstruct the inflow of blood into the ventricles.
So the heart can't fill.
Because the heart can't fill, it can't pump, and cardiac output can drop to zero. It's a mechanical crisis.
What are the typical causes that lead to this sudden pressure buildup?
Well, while large effusions from idiopathic pericarditis can cause it, the highest risk scenarios involve bleeding or very rapid fluid accumulation. This includes trauma, complications from cardiac surgery, leakage from an aortic dissection, metastatic cancer,
As we just discussed.
and bleeding caused by the inappropriate use of anticoagulants. Tuberculosis is also a common cause globally, often leading to these big bloody effusions.
And here is a core concept for the listener. Volume doesn't always equal danger. Time is the key variable here.
That's the vital distinction in tamponade pathophysiology. If you have an acute bleed, say from a trauma, a rapid accumulation of just 200 milliliters of fluids can overwhelm the rigid, non-stretching pericardium, and that can lead to immediate fatal tamponade.
Just 200 ml out.
But if the fluid accumulates slowly, maybe over weeks from a chronic viral or cancerous effusion, the pericardium can gradually stretch and accommodate it. In those slow onset cases, the heart may tolerate massive effusions, sometimes over 2,000 milliliters, 2 liters, before clinical signs of tamponade actually manifest.
Wow. When tamponade finally does hit, the physical presentation is classic, often summarized by Beck's triad.
Beck's triad is the textbook signpost. First, the patient is hypotensive. They have low arterial pressure because the restricted filling means very little blood is leaving the heart. Second, the heart sounds are soft or completely absent because the large volume of fluid is muffling the noise. And third, jugular venous distension, or JVD. The neck veins are visibly bulging, but because the pressure in the central veins is extremely high, blood can't get into the heart.
Within that JVD finding, the specific hemodynamic tracing you see in the neck pulse is one of the most critical diagnostic tells.
It's the unique signature of the pressure. We look at the atrial pressure pulse, which typically has two descents, the X descent and the Y descent. In tamponade, you see a prominent X descent, which reflects the fall in pressure as the atrium relaxes during systole. But, and this is the key, you will see a distinctly absent Y descent.
Okay, explain to us why the Y descent disappears in tamponade. What's happening mechanically?
So the Y descent represents the rapid drop in atrial pressure that happens during early diastole when the mitral and tricuspid valves open and the ventricles rapidly suck blood in to fill.
Right, the initial filling phase.
In tamponade, the heart is being physically squeezed by that tense fluid throughout the entire cycle. That rigid external pressure prevents the ventricles from expanding quickly enough to draw in blood during early diastole. So no rapid filling means no rapid pressure drop in the atria, and thus the Y descent is completely obliterated.
That makes perfect mechanical sense. Now let's tackle the other great physical sign that is often counterintuitive. The paradoxical pulse, or pulsus paradoxus.
This is a hallmark physical finding. It's defined as a drop in systolic arterial pressure of greater than 10 millimeters of mercury during normal inspiration. If the tamponade is severe, you might even feel the radial pulse at the wrist completely disappear when the patient takes a breath in.
So what is the mechanical explanation for this dramatic drop, given the heart is trapped in this rigid sac?
It's a concept called ventricular interdependence. When we inhale, the negative pressure in the chest draws more blood into the right side of the heart, increasing the right ventricular, or RV, volume.
Okay, normal physiology.
Normally, this is fine. But in tamponade, the total volume within the closed, rigid pericardial sac cannot increase. So as the RV expands to accommodate that extra blood from inspiration, it has nowhere to go but inward.
It pushes on the left ventricle.
Exactly. The interventricular septum, the wall dividing the chambers, bulges sharply to the left, physically reducing the space available for the left ventricle to fill. This drastically reduces the LV's stroke volume, meaning less blood is pumped out to the body and the systemic blood pressure drops dramatically. That drop is the pulsus paradoxus.
Given the urgency, how is tamponade diagnosed right there at the bedside?
Echocardiography is the undisputed primary diagnostic tool. It's rapid, non-invasive, and available immediately. It visually confirms the echo-free space, the fluid effusion, and critically, it shows the effect of the pressure.
What are you looking for?
We look for signs of impending collapse. The inward motion and compression of the right ventricular free wall, often seen during late diastole, and the collapse of the right atrium.
And Doppler ultrasound can confirm the physical mechanics we just discussed.
It locks in the diagnosis. Doppler visually confirms that exaggerated respiratory variation. During inspiration, because the RV is preferentially filling, the flow velocity through the tricuspid and pulmonic valves increases markedly.
While at the same time.
Simultaneously, the flow velocity through the mitral and aortic valves on the left side decreases drastically. It's a beautiful visual confirmation of the physiology. If the effusion is unusually loculated, sort of compartmentalized, we might need a CT or MRI to precisely map out those fluid pockets.
Since this is a massive physiological crisis, the treatment has to be immediate mechanical relief.
It is a true medical emergency. If signs of tamponade are evident, pericardiocentesis, draining the fluid with a needle, must be performed immediately. The most common technique is the subsophifoid approach, guided by echocardiography to ensure the needle is positioned correctly and safely.
What about supportive measures while you're prepping for the procedure? Can you do anything?
You might buy a few precious minutes by administering intravenous saline. Increasing the volume slightly raises the central filling pressure, which can temporarily stabilize the circulation. But this is just a bridge. The procedure itself must not be delayed, as it is the only definitive cure for the acute compression.
Once the fluid is extracted, what do you look for in the analysis?
We analyze the fluid for everything: cell counts, culture, cytology. In Western developed nations, bloody fluid is most commonly linked to malignancy, renal failure, or trauma. But if we're dealing with bloody or high-protein exudative fluid in a setting of high endemic risk, like in many developing nations, it strongly suggests tuberculosis as the underlying cause.